Welcome to the Deep Dive. We slice through complex info to get to what really matters, and today we're tackling something huge: chest pain in the ER.
Yeah, it's one of the absolute top reasons people show up. And the real challenge, the thing that makes it so tough, is just how many different things can cause it.
Right, it's incredibly diverse.
It is. And differentiating, telling apart something fairly minor from something genuinely life-threatening, that's incredibly hard, even for experienced doctors.
And you mentioned something striking, that patients who are critically ill can actually look, well, almost normal initially.
That's the core aha moment, really. Someone could have a condition that needs immediate life-saving intervention, but their vital signs,
Yeah.
stable. The first physical exam might seem okay. It's a massive puzzle.
Wow. Okay, so it really is like medical detective work then.
Pretty much, yeah, under intense pressure.
So our mission here today in this deep dive is to sort of unpack that journey. What happens when someone comes in with non-traumatic chest pain? What are the steps, the tests, the thinking process?
Exactly. We want to show you the kind of precision and, frankly, the high stakes involved in figuring this out quickly and accurately.
Okay, let's get into it. The landscape of chest pain.
Hmm.
You said it's diverse. What kind of things are we actually talking about?
Well, everyone thinks heart first, right? And that's definitely high on the list. But the pain could be coming from the aorta, that huge artery leaving the heart,
Okay.
or the lungs, the esophagus, even the stomach. And then you've got the muscles, the bones around the chest cavity itself.
Yeah.
It's a lot of potential sources packed into one area.
It really paints a picture of the complexity. So with all those possibilities, the first job is figuring out what could kill you, like right now.
Absolutely. Rule out the immediate life threats. Our sources lay out a kind of most critical list.
What's on that list?
Okay, so think categories. For the heart, you've got acute coronary syndrome. That's the umbrella term for heart attacks and unstable angina. And pericardial tamponade, where fluid builds up and basically strangles the heart. Then vascular stuff like acute aortic dissection, a tear in the aorta, really bad.
Okay, heart, aorta.
Lungs, pulmonary embolism, a blood clot that travels to the lungs, or tension pneumothorax, a collapsed lung that's putting pressure on everything, including the heart.
Collapsed lung, okay.
And even gut problems can present as chest pain. A perforated peptic ulcer, or mediastinitis, which is a severe infection in the chest, often from a ruptured esophagus. And that's not even exhaustive. There are others like myocarditis or Takotsubo cardiomyopathy too.
That list alone is intense.
Ah.
So how does the evaluation actually start when someone comes in?
It kicks off immediately with a focused history and examination. Think of it as super fast triage. The number one goal is this patient stable? Are there immediate signs of a life-threatening problem?
And this is where those red flags come in.
Yeah.
Even if someone seems okay on the surface, certain signs scream danger, right? What are they looking for?
Yeah, absolutely critical. Abnormal vital signs are a huge one. So really low blood pressure or a super fast heart rate, breathing way too quickly, or obviously struggling for air.
Okay, vitals. What else?
Signs of distress, like are they sweating buckets? Do they seem really anxious, confused, or just not quite mentally there? And then signs of what we call hypoperfusion, basically, not enough blood getting around. That could be cool, clammy skin, weak pulses, or again, that altered mental status.
Got it.
But one of the really specific ones is how the pain started. If it was abrupt, severe chest pain, especially if they describe it as sharp, tearing, or ripping.
That's the aortic dissection one you mentioned.
Exactly. That description sets off major alarm bells for dissection.
Yeah.
Also, big differences in blood pressure between arms or a pulse missing somewhere. Those are also major red flags.
Okay, sharp tearing, ripping, definitely memorable. So those flags are waving. What happens next, like immediately?
If the patient is showing signs of hemodynamic instability, meaning their circulation is failing, blood pressure is dropping, heart's not coping, then immediate resuscitation is the absolute priority. We need to stabilize them fast.
Stabilize first. How? What are the first actions?
It starts with ABC, right? Airway and breathing. Do they need help keeping their airway open? Do they need oxygen? Usually we aim for oxygen saturation around 90, 94%.
Okay.
But here's an interesting point from the sources for someone having an acute coronary syndrome, like a heart attack. If their oxygen levels are already normal, giving them extra oxygen might not actually help. It's a specific nuance.
Huh. That is interesting. Okay, so airway, breathing, then C, circulation.
Exactly. Get IV lines in for fluids, for medications, draw blood samples right away, especially for those cardiac markers we'll talk about later. Get them on a continuous heart monitor, an ECG, and make sure all the emergency gear, defibrillator, airway cart is right there, ready to go. If they have a life-threatening heart rhythm like VFib or VTach, you treat that immediately using advanced cardiac life support protocols.
Right, ACLS. And what if they're in shock? You mentioned fixing the root cause.
Yes, that's key. If someone's in shock because of something specific, like that tension pneumothorax or pericardial tamponade, you have to treat that specific thing first. Sticking a needle in to relieve the pressure or drain the fluid, just pouring in fluids or using drugs to raise blood pressure won't fix the underlying mechanical problem.
Makes sense. Fix the cause.
And there are specific things to watch for, like if you suspect a heart attack affecting the right side of the heart, you have to be really careful with certain medications.
Okay. And are there any immediate meds almost everyone gets?
Aspirin is a big one. If acute coronary syndrome is suspected, they'll usually get aspirin to chew, typically 162 to 325 milligrams, unless there's a reason not to, like active bleeding.
Got it. Aspirin. Okay, so that covers the immediate life-saving stuff. Once things are a bit more stable, or if the patient wasn't unstable to begin with, the detective work really ramps up. And you said the patient's story is key.
Absolutely crucial. The history they give you is probably the most powerful tool for narrowing down what's going on. You need the details.
Like what sort of details?
Onset and timing. Was it sudden? Like, bam, instant pain. That points towards things like dissection, maybe a pneumothorax or PE. Or did it creep up gradually, which might be more like stable angina?
Okay, sudden versus gradual.
Is it constant pain or does it come and go? When exactly did it start? What were they doing? Did anything trigger it? Like exertion, big emotional stress, even a recent meal?
Right. And the pain itself, what does it feel like?
Yeah, the quality. Is it pressure, tightness, squeezing, sharp, tearing, burning? Where is it? Dead center, off to the left. Does it radiate anywhere down the arms, up to the jaw, into the back?
So many questions.
And what makes it better or worse? Does resting help? Does changing position make a difference? Does nitroglycerin help? That's a classic question for cardiac pain.
What about other symptoms that go along with it?
Hugely important. Are they sweating, feeling nauseous, vomiting? That's common with heart attacks, but other things too. Shortness of breath, cough. Coughing up blood, that suggests lung involvement.
Okay.
Any neurological symptoms? Dizziness, weakness, vision changes. That could pop up with aortic dissection, maybe even a stroke presenting atypically.
And risk factors, I assume, play a big role?
They do. You ask about all the standard cardiovascular risks.
Yeah.
Age, family history, smoking, high blood pressure, diabetes, high cholesterol.
Sure.
But also specific risks for specific conditions, like for aortic dissection, uncontrolled hypertension, certain connective tissue diseases, even cocaine use. For PE, recent surgery, being stuck in bed, pregnancy, cancer.
And their past medical history. Previous heart issues.
Definitely. Have they had a heart attack before? Angina, stents, bypass surgery, any recent stress tests or other heart investigations? All crucial pieces. It's a lot to piece together.
It is. And here's another really key point from the sources. Acute coronary syndrome doesn't always present with classic chest pain. These atypical presentations are common.
Atypical. Like, how?
Someone might just feel short of breath, or profoundly weak, or just nauseous, especially in older adults, women, and people with diabetes. They might not have that textbook elephant on the chest feeling at all.
That's huge. So you can't just rely on the classic symptoms.
Exactly. You have to listen really carefully, consider the whole picture. Risk factors help, but you can have a life-threatening condition even with no traditional risk factors. It's about putting all the clues together, not just checking boxes.
Okay, that really emphasizes the complexity. After gathering that whole story, what about the physical exam? You said findings can be subtle.
They often are, frustratingly. But sometimes you find important clues. For aortic dissection, maybe a new heart murmur, or that difference in pulses or blood pressure between arms we mentioned, maybe signs of shock or even neurological deficits.
Okay. And for pulmonary embolism, you might hear some localized wheezing, or notice breath sounds are quieter on one side, or maybe one leg is swollen, suggesting a deep vein thrombosis, a DVT, which is where the clot likely came from.
Right, the DVT link. And for ACS, the heart attack spectrum.
Often the exam is surprisingly normal. That's part of the challenge. But you might find signs if heart failure is developing crackles in the lungs when listening, maybe an extra heart sound called an S3, swollen neck veins, or swelling in the legs.
Okay. I also saw mention of specific sounds, like a friction rub for pericarditis.
Yes, pericarditis inflammation around the heart can cause a rubbing sound, like leather rubbing together heard with a stethoscope.
And that Hammond's crunch for mediastinitis.
Yeah, that's a rarer one, but very specific if you hear it. It's this kind of crackling, crunching sound over the heart, synchronized with the heartbeat. Usually means there's air in the mediastinum, the space between the lungs, often from that esophageal rupture.
Wow. Okay, so subtle clues, but potentially very revealing. Now let's move on to the diagnostic tests. The arsenal, as you called it. ECG first.
Electrocardiogram, yeah, standard of care, basically.
Yeah.
Almost everyone with chest pain gets one, especially if there's any suspicion of a cardiac cause. The goal is interpretation within 10 minutes of arrival.
10 minutes. Fast.
Very fast. It can show immediate signs of a heart attack, like ST elevation or other electrical problems, arrhythmias. It's a crucial first look.
Okay. Then the chest x-ray, the CXR.
Yep. Usually done, typically front and side views. It can diagnose some things outright, like a big pneumothorax, a collapsed lung. You can see that clear as day sometimes.
But. I sense a but.
Big but. And this is really important. A normal chest x-ray absolutely does not rule out killer conditions like ACS or PE.
Okay, that's critical. A normal x-ray doesn't mean you're safe.
Not at all. It can provide a false sense of security, which is dangerous.
Yeah.
You can have a massive heart attack or a significant PE with a completely normal-looking chest x-ray.
So clinicians can't just stop there if it looks okay.
Definitely not. Interestingly, though, the sources say about 90% of patients with an aortic dissection will have some abnormality on their chest x-ray. Not always obvious, but something's usually off.
That's a useful statistic. So what kind of abnormalities are they looking for on CXR?
Well, things in the lungs themselves, fluids suggesting heart failure, patches indicating pneumonia. They look at the mediastinum, that central chest area. Is it wider than usual? That's a classic, though not perfect, sign of aortic dissection.
Widened mediastinum. Okay.
They look for that collapsed lung line, the visceral pleural line, or free air under the diaphragm. That's a sign of a perforation, maybe a stomach ulcer that's burst.
Lots to look for. Okay, moving on to lab tests. Troponin seems to be the big one for hearts.
It is. Cardiac troponin is the main blood test for diagnosing acute myocardial infarction, a heart attack. We use high-sensitivity assays now, which pick up smaller amounts sooner.
High sensitivity, okay.
And you often need serial measurements testing it again after a few hours because it takes time for troponin to rise in the blood after heart muscle damage starts.
So one test might not be enough.
Often not. But another key point, while troponin is the heart attack marker, other things can make it go up too. Severe kidney failure, heart failure, even PE can cause elevated troponin, so it needs context. It's not just a simple yes-no test for MI.
Good point. Context is key. What about D-dimer?
D-dimer is mainly used as a rule-out test. If someone has a low or maybe moderate chance of having a pulmonary embolism based on their story and exam, a negative D-dimer test makes PE very unlikely.
So it helps rule out PE.
In the right patient group, yes. It can also be used sometimes along with a scoring system to help rule out aortic dissection too. But it's not great for ruling in these conditions. Lots of things can make D-dimer positive.
Okay, a rule-out tool. What other blood tests are standard?
A full blood count, or CBC, might show high white cells in infections or inflammation like myocarditis or pneumonia. Checking kidney function is vital for managing fluids and medications. And sometimes a BNP-level B-type natriuretic peptide, which can help tell if shortness of breath might be due to heart failure. Coagulation studies, if they're on blood thinners or bleeding, is a concern.
Okay, quite a panel. Now, something that seems increasingly important is bedside ultrasound, right? There in the ER.
Huge. Point-of-care ultrasound, or POCUS, performed by the emergency clinicians themselves, is a game changer. It lets them look inside, right there, right away.
What can they see with it?
Critical stuff. They can often directly visualize pericardial tamponade, see the fluids, see the heart being squeezed. They might see signs of aortic dissection, like the flap inside the aorta or the aorta being dilated. They can diagnose a pneumothorax by looking for lung sliding.
Wow. Direct visualization of life threats at the bedside.
Exactly. And it's great for assessing the heart's function, too. Are parts of the heart wall not moving well? That suggests ischemia, like an ACS. Is the whole heart weak? Maybe myocarditis, signs of heart failure, right heart strain, suggesting a PE.
So it gives functional information too, not just anatomy.
Yes. They can look for DVTs in the legs if they suspect PE, look for signs of pneumonia in the lungs, or fluid collections. It's incredibly versatile.
It really sounds like a powerful tool. Finally, the big guns. Advanced imaging, like CT scans.
Computed tomography, yeah.
Right.
Often, if the diagnosis isn't clear after the initial workup, CT is the next step because it's so good at seeing almost everything in the chest.
Versatile, you said.
Extremely. A single CT scan, depending on how it's done, can diagnose or rule out aortic dissection, pulmonary embolism, pneumonia, pneumothorax, problems in the mediastinum, even injuries to the chest wall.
So specific types of CT for specific jobs.
Right. For suspected aortic dissection, a CT angiogram is usually the first choice. It's fast and widely available. For suspected PE, it's a CT pulmonary angiogram, or CTPA. And sometimes, for certain low to intermediate risk patients, a CT coronary angiogram, CCTA, can look directly at the heart arteries.
Okay, so bringing this all together, it's this incredibly complex process, isn't it? From that first assessment, the red flags, the immediate life-saving steps, through the deep dive into the story and exam, and then deploying this whole range of tests.
It really is an intricate dance. Clinicians are acting like detectives, piecing together clues, weighing probabilities, often under immense time pressure, trying to find these potentially lethal conditions that, as we said, can be really good at hiding.
It's quite humbling to think about the expertise involved.
It truly is. The stakes couldn't be higher, and it demands so much knowledge, skill, and careful judgment.
Which leads us perfectly to our final provocative thought for you listening. Given everything we've discussed, the sheer complexity of chest pain, how subtle it can be, how life-threatening conditions can hide behind normal appearances, how does understanding this whole process change how you think about symptoms? Maybe about advocating for yourself or others? And what does it tell you about the incredible level of expertise working behind the scenes in emergency medicine every single day?